or good morning, depending on what time zone you're in. Thank you all so much for joining us today for the latest Innovation Hub Learning Community webinar titled Who's Guiding Your Choices? Centering Community in Evidence-Based Decision-Making. This is our final quarterly webinar for the year, and we are really excited to talk to you today about all things evidence and how you can intentionally center community and community preferences and community voice when making decisions. I am going to quickly stop sharing my screen and reshare just to switch. Hold on just a minute. Okay. All right, wonderful. And we are going to go right ahead and get started. So as I mentioned, this is one of the webinars for our Innovation Hub Learning Community. This webinar series focuses on strategies and skills you can apply to your work to improve your organizational processes, expand the scope and impact of your practice, and plan for program sustainability. It is open to all Innovation Hub, open to all, not just Innovation Hub practices. Some of our Innovation Hub Learning Community opportunities are specific for folks who have practices in the Innovation Hub database. Those are our peer sharing groups and customized coaching, but these webinars are open to all. I should actually take a step back and introduce myself. My name is Laura Powis, I use she, her pronouns. I'm the Senior Program Manager for Evidence-Based Policy and Practice here at AmChip, and I lead our Innovation Hub Learning Community, and I'm joined today by my colleague, Michaela Fry, who is going to be talking to us about assets-based approaches. So as I mentioned, there are three main types of opportunities for the Innovation Hub Learning Community: the quarterly webinars, peer sharing groups, and customized coaching. As I mentioned, this is the last of our quarterly webinars for 2023, so stay tuned for more information about upcoming opportunities in 2024. And for folks who are Innovation Hub practices, if you have any sort of struggle points you're working through right now in your work, you could use some guidance or another perspective, or you're curious about how you could apply more evidence-based approaches to the way that you are doing your work, we are here to help you. If you connect with us, we're always available for kind of customized one-on-one support and coaching. So really just reemphasizing that we're here for you in a variety of different ways, one of which being these webinars. So today, just to kind of walk us through our agenda, we're going to start by talking about evidence-based decision-making overall, what that means to make evidence-based decisions in a way that centers community-based evidence. We'll then deep dive into applying an asset framing to maternal child health challenges. And then we're going to spend a lot of time today also applying a tool that AmChip has as a way to help ensure that when you are considering potential solutions to MCH challenges, you're doing so in a way that really does center community voice and applies an assets-based lens. So we will have an opportunity to go through this case study together, and then we will have some time at the end for wrap-up and questions. So just to further lay out the roadmap, by the end of this session, you'll be able to describe how evidence comes in many forms, including the perspectives of people with lived experience, understand how applying an assets lens to framing MCH challenges and making evidence-based decisions can influence narratives, explain the importance of centering people with lived experience when exploring potential solutions to MCH challenges, and applying the 6 considerations planning tool to when considering solutions to MCH challenges. So let's just dive right on in. So for evidence-based decision-making, folks might have heard of that term before. You may be familiar with what this is. A lot of our work that we do in Title V is using evidence-based decision-making, but it's still important for us to take the time to kind of break it down to its fundamental steps. Which the most fundamental is, what is evidence, right? So when we think about evidence, there's different things that might come to mind. When we've asked this question before, we've heard from folks, proof is an example of evidence. When we think of evidence, we think of proof, we think of data, we think of empirical tests. Some folks think about community perspectives, community opinion, focus groups, qualitative data. There's a whole wide array of things that we think of when we think of the word evidence. And this variety of answers really shows that that there are many different mental models we hold in maternal and child health regarding what is considered evidence. You might be wondering, why does it really matter what we consider evidence? What we consider evidence within the context of our work as public health professionals determines which programs and solutions are funded, what research is prioritized and conducted, and also whose voices are deemed credible and valuable. Of note, from 2005 up until 2021, initially in 2005, if you were to look at all of the notice of funding opportunities, NOFOs released by HRSA, only 5% around used the term evidence-based in those NOFOs, requiring folks to submit evidence-based strategies or approaches. And then by 2021, that number was up to about 50% of NOFOs were requiring evidence-based practice. And so really what this is showing us is that there's been this huge uptick in the emphasis on the importance of including evidence-based work in our public health approaches, which is a positive thing. It's a really great thing to make sure that we're doing work that is well-informed, not reinventing the wheel, but it's also really important to think about what are we considering in that evidence base? What are we deeming as evidence? Because that really does determine whose voices are credible and valuable. Inadvertently, there can be this cycle of exclusion for community-based organizations from these different funding opportunities if their work is not deemed evidence-based. So if we're applying a perspective on what is evidence that really focuses on research empirical evidence, that can unintentionally or intentionally exclude community-based organizations or relegate them to more supplemental roles on proposals. Say a community-based organization doesn't have the staff power or bandwidth or interest in conducting the type of large-scale evaluation that would deem something to be evidence-based under certain kind of evidence paradigms or ways of thinking about what is evidence-based. That might mean that they are not eligible to receive certain types of funding. Breaking the cycle of exclusion requires shifting how we consider and value evidence. So when thinking about evidence, AMCHIP really considers three main types of evidence that we're going to go into in a moment: contextual evidence, experiential evidence, and research evidence. And at the intersection of those three types of evidence comes evidence-based decision-making. So that's really when we're making choices based on the confluence of the best available of all of these three types of evidence. So every time we're considering an MCH challenge, every time we're considering potential solutions, we're really wanting to ground and think not just about what's the research evidence to back that this approach is going to work, but what's the contextual evidence that shows the fit for our community that we're working with, and the experiential evidence of people with lived experience and providers and professionals who engage with the communities you're working with. So there are three main types of evidence that AMCHIP thinks about. So the first is research evidence. And so this is information that comes from scientific evaluations that helps determine if a program or strategy is achieving its intended outcomes. Some examples of these might be peer-reviewed journal articles, randomized control trials, systematic reviews, quasi-experimental or experimental designs, sort of what you typically think of when you, at least for me, when I typically think of evidence, sort of what I was taught in school, this is usually where my mind goes, is to research evidence. Next is contextual evidence. So this is information about whether a program or strategy fits the social, political, and environmental context in which it will be implemented. So contextual evidence is really important, not just in thinking about fit, but also considering in its own right that this can be something that demonstrates the impact of a program or the work that we're doing. So this can be information, Title V does a lot of this through our needs assessment work. So this can be information collected through focus groups, through town halls, through community surveys. It can also often, we have a lot of examples of practices and policies rooted in contextual evidence in our Innovation Hub as well. And then the third type of evidence is experiential evidence, which is the collective experience and expertise of those who have practiced in or lived in a particular setting, and includes the knowledge of subject matter experts. So these could be national guidelines or standards, so things put out, say, by ACOG or the American Academy of Pediatrics, the kind of congregation of all of the expertise of a wide array of providers, say, who might be working on like adolescent mental health, for example. Guidelines around that could be an example of experiential evidence. A lot of our needs assessment work also can be when you're conducting key informant interviews, when you are conducting focus groups with families or parents, that can also be an example of experiential evidence. And so a couple things I want to pull out before I hand it off to Michaela to talk about assets framing. So within contextual evidence, there's a certain type of contextual evidence called community-defined evidence. And what community-defined evidence is it's a set of practices that communities have used and found to yield positive results as determined by community consensus over time. These practices may or may not have been measured empirically, but have reached a level of acceptance by the community. And so an example of something that might be a really strong example of a practice that's rooted in community-defined evidence, but does not have a lot of empirical evidence, or it might have some experiential evidence, would be, I know we've worked in the past with a really wonderful program based out of Philadelphia that was a care coordination center for children and youth with special healthcare needs and their families. And it provided care coordination, and had been in the community for 20, 30 years. It had been a really long time. Families who had gone through the program went back to work for the program, just really spoke very, very highly. It was regarded by the community as being kind of a cornerstone program, an approach that was really meeting the needs, the complex needs of these families and these individuals. And it kind of really showed that community acceptance over time, that community investment, but they didn't have any, they had some preliminary evaluation data, but they did not have necessarily like any sort of study or formal evaluation that had been conducted. And so that's an example of kind of what we mean when we're talking about community defined evidence. So really thinking about what does it look like for communities to define what success looks like for themselves, and what does impact look like. And so something I really want to raise too is looking at the image on the left here, you'll see that it's a Venn diagram. There is overlap between these different types of evidence. We are not saying that evidence is at war with each other, that research evidence does not matter. We're really just saying that when you're making evidence-based decisions, you're needing to consider all of these types of evidence to ensure that you are making the most informed decision, that you're investing your time and energy in programs and policies that are going to best meet the needs of the communities that you're working with. So you'll also notice that some of them overlap, right? A lot of contextual evidence could also be considered experiential evidence, or if you're familiar with community-based participatory research, that can be a really strong example of research evidence and contextual evidence mixing. Our goal here in presenting these different types of evidence is really just to encourage you to think comprehensively and holistically when considering what sorts of strategies or approaches might be effective at doing your work, or when you're considering what's the impact of the programs that we're doing or the programs that we're funding, right? To think outside of just quantitative numerical outputs, to really think about kind of the more holistic picture that captures the experiences and preferences of the folks that you're serving. So that was the kind of very high level, fast explanation of evidence-based decision making and what that can look like. And with that, I'm going to hand it over to Michaela to talk about applying an asset frame to considering solutions to MCH challenges.
Thank you, Laura. They just started drilling, so I apologize if this gets a little loud. They're doing construction, the building next to mine. So I might pause here and there while it gets really loud, but that's just the name of the game. But thanks. Hi, everyone. My name is Michaela Fry. I usually hear pronouns, and I'm a program manager at AmChip on our workforce development capacity building team. I have a background in epidemiology, but now work with workforce development. So I'm excited to be talking about asset framing and how to marry asset framing and evidence-based decision making. Okay, next slide. So we are going to be talking about asset framing and its relation to evidence-based decision-making, but first we should be defining and exploring what deficit framing is. Deficit framing is the act of defining people by their problems, often through the lens of outside experts. Additionally, deficit framing does not give us a clear vision of the future, but instead focuses on the problems and on the adverse experiences of the past. And I mention this and bring deficits framing to the forefront because unfortunately, deficits framing is the dominant narrative framework in public health. And many, if not all of you, have probably seen language that mobilizes deficit framing. We often use deficit framing language to describe our missions and visions at nonprofits or governmental public health organizations. Not because we inherently want to paint communities as riddled with problems, but often because we're trying to emphasize and communicate a crisis or a health issue of some sort, or to acknowledge disparities in health outcomes, for example. Next slide. So for example, with deficit framing, these two excerpts have actually been pulled from two different states' Title V Block Grant and reports. These have been de-identified to protect the state, but I just wanted to look at how these two states employ deficits framing to emphasize how their programs are addressing current health disparities. So it can be really interesting thinking about deficits framing as it relates to health disparities and how people and programs and organizations talk about their work to increase health equity by using deficits framing language. So for this first example, the MCH program continued to contract with local health departments to promote the health of mothers and infants by assuring prenatal, delivery, and postpartum care for low-income and at-risk pregnant women. So just from this example, we can identify a couple spots where deficits framing is really shining through. The most obvious being the use of low income and at risk to describe a population. Defining people by the challenges they face is stigmatization and a product of deficit framing. I'm going to move on to the other example because we will be revisiting these later on in the presentation, so we will have more time to unpack these. The second example says, as birthing people who receive intraconception care tend to have healthier pregnancies and lower risk births, this strategy may help lower rates of maternal morbidity and mortality, particularly where there are disparities. Intraconception care is particularly critical for Black and African American birthing people who have the highest infant and maternal mortality rates of any racial group in the United States. This one may be a little bit trickier to figure out like where the deficits framing is really coming through. But one thing that I did notice was that by framing and defining the Black and African American birthing population as their relationship to mortality, morbidity, and adverse outcomes, that was the deficits framing that popped out to me, and just for an example. Okay, next slide. So what is asset framing? If we don't want to be using deficits framing, how can we better frame our communities and talk about our communities? So asset framing is the remedy to deficit framing. And as opposed to deficit framing, asset framing is defining and framing people first and foremost by their aspirations and contributions, not their problems. It's not about ignoring the hardships communities face, but rather to focus on their strengths, gifts, talents, aspirations, contributions, and assets before and during sharing the hardships and challenges they do face. So by focusing on aspirations and contributions, you can set the stage for forward-focused solutions whose main goals are to support people in achieving their dreams and actualizing their value, as opposed to solutions that focus on fixing people in their communities. Moreover, asset framing looks beyond the individual into the systemic and structural. There is no asset framing without acknowledging the historical context and conditions that influence the health of communities today. There is no asset framing without acknowledging the political, the cultural, the social conditions that impact the health of communities. And there is no asset framing without implicating systemic oppression, structural violence, and systemic discrimination as root causes of health disparities and poor health outcomes. Next slide. So I just wanted to share this like side-by-side comparison of deficits versus assets framing that really draws our attention to what the two framing structures measure and what the two framing structures value. So for one, when we're thinking about indicators and what we're measuring, deficits framing focuses on things to address, such as like poverty, poverty rates, suicide rates, alcohol use, foster care. Whereas an assets framing would think about things to build upon and measuring the assets and strengths of communities, such as cultural identity, social connections, health and wellness, and resilience. Deficits framing centers the perspective of outside experts, while assets framing centers the perspective of family and community wisdom. And when we're thinking about our focal lens and the way that we're operationalizing and considering, our programs, deficits framing really focuses on like intervention. You'll see things like broken families, broken communities, adverse experiences, fixing problems, and thinking a lot about like risks and reducing risk. As for assets, it focuses on relationships, and building equity and well-being and self-determination and having a clear vision of the future through those. Okay, next slide, I think. Thank you. And so while those were more of a framework for how these frames work and what they value and what they measure, there are some actionable steps that we can take to start shifting the narrative from deficits framing to assets framing during this presentation. So harm reducing language is a big way in which we can start shifting this narrative. And my colleague Salome, who is on the call today, has been really instrumental in advancing harm reducing language at AMTIP and with our partners and members. And I just wanted to first and foremost give her due credit. So I just wanted to shout her out. She's done a lot of work with this and can probably do a way better job than I am. But harm reducing language is language that avoids stigmatizing individuals for the conditions that they experience as a result of systemic imbalances of power. So harm reducing language also directs attention to the root causes of inequity and redirects blame from persons affected to acknowledging the perpetual harm caused by systems and structures that hold power and privilege. So an example of this is using terms such as, high risk, at-risk groups, at-risk populations, thinking about marginalized groups and targeted populations. So these terms can be stigmatizing. They are vague, they are not specific. When people say at-risk groups, you don't really know who they're talking about. You don't know what communities they're actually focusing on. And these terms can also imply that the condition is inherent to the group and does not at all include systems and structures as the root cause. So instead of using this, we can use language such as groups that have been marginalized by X, Y, and Z, have been marginalized by white supremacy, have been marginalized, by the healthcare system, or groups placed at higher risk of such outcome. And then at the bottom, another example is like using violent language when we're thinking about like targeting people, thinking more about like engaging and prioritizing and shifting that from a deficits lens to an assets lens. Okay, next slide. So now this is a little, we can try our hand at shifting and reframing the narrative. I think all of you should have access to the chat. Thinking back to the asset framing strategies, such as like leading with history and context and systems and using harm reducing language. What are a few ways we can change this first example to be more aligned with asset framing than with deficit framing? I'm not asking for the whole rework of the example, but if people could put in the chat you know, what we can use, what language we can use, how we can maybe reframe this first example to be more assets based. And I'll just give you a minute. Feel free to put your ideas and thoughts in the chat as they come to you. I'm not seeing anything come in. So my dear friend Laura, is there anything that sticks out to you about this example that we could change to make it more assets framed?
I think what jumps out to me initially is the use of at-risk pregnant women or low income, just like really defining folks by those kind of deficit based language, whereas I feel like we could change that to be, you know, historically under-resourced communities, or like women from historically marginalized women's of like historically marginalized identities, or terms to that effect.
Yeah, absolutely. Yeah, and I saw Michelle's comment. Thank you so much, Michelle. It says, who have the greatest potential for improved health outcomes. I love that. Yeah. Really tapping into people's potential, you know, their value, their dreams. And so this is just something that I wrote. This is by no means the answer. This is something along the lines of the MCH program continued to contract with local health departments to provide mothers extra support that they can fulfill their dreams of a healthy pregnancy, delivery, and baby. So just really acknowledging that people have plans and have dreams to have, you know, health outcomes that are positive, and really tapping into those. Thank you again, Michelle, for participating in that. Okay, second example. I know this one is much longer and a little less direct, but any ideas on how we can start shifting this to be a little bit more assets free? Okay, so I mentioned earlier that what stuck out to me about this one was defining, you know, Black birthing people as their relationship to morbidity and mortality. And so what I came up with was, Laura, could you click? Thank you. Was that despite having dreams and plans for healthy pregnancies and deliveries, Black and African American birthing people experience the highest rates of maternal morbidity and mortality due to centuries of structural racism. Interconception care is a powerful approach that provides birthing people the opportunity to attain their plans for healthy pregnancies and deliveries, and may lower rates of maternal morbidity and mortality, particularly where there are disparities. So that was just my hand at reframing this from deficit space to an asset framing, where I was trying to really center the plans and dreams of Black birthing people to have healthy pregnancies and deliveries, how interconception care can attain that. And I mentioned before that asset framing does not mean that we're ignoring hardships or disparities. So I also made sure to include that there are hardships and disparities there, which is why we're trying to do this work. Yeah, and then making sure that the systems and structures were acknowledged as the root cause. And I see your comment, Michelle, about this was difficult because we in public health, we do consistently focus on deficits. I'll be honest with you, when I was reading these too, it took me a while to come up with a reframe. Like this wasn't a like 2-minute practice. And so don't think that because you couldn't think of anything in like the minute, that I gave you that there's something wrong. This is really hard, challenging work. Like we're training ourselves to rethink about how we communicate and how we can train to communicate in public health. So I really do appreciate that comment, Michelle. And you're not alone at all. Yeah. Okay, next slide. Thank you. So you might be thinking like, okay, what's the big deal here? It's just, words, just language. Why should we start using asset framing when deficits framing has been getting us by this whole time, right? Especially in like grant proposals. That's how we get our money, is talking about all of the things that we're going to fix. But as we saw in our activity, using asset framing reorients the narrative around communities and their strengths. And assets are capital to build upon, they are investments, they encourage forward and future thinking, whereas deficits are something to address and conquer. Assets provide community with opportunities to self-determine, to strengthen fair and reciprocal relationships. And by focusing on asset framing, we have the power to transform what the narrative says and what we believe about different communities. Thinking about the way we're messaging around communities and how that shapes our belief about who they are as people. And I wanted to take an example from Richard Chase's article in the Minnesota Compass about race and ancestry data and how that has been used as a proxy for problems and trouble and deficits. So before the end of the 20th century, and I would argue, still to this day, researchers and policymakers oft conflated being Native American with being like a risk, a health risk. We see that today, and also for Black people. Think back to our example, of like Black or African American women, are inherently at risk. There are risks for maternal mortality. They are risky. Our public perception has begun to change on that a little bit by the immense work, that Native American and other Black, Indigenous and other people of color have been doing to begin leveraging cultural identity as an asset and protective factor against, these common health outcomes that we associate with, Native Americans, such as like suicide, alcohol use, other conditions that have a higher prevalence in Native communities. Instead of referencing Indigenous heritage as a barrier to positive health outcomes, cultural heritage was viewed as a vital asset and a tool to instill positivity and confidence in youth. And the great embodiment of not only this narrative reorientation, but using asset framing and evidence-based decision-making is the work that the White Mountain Apache tribe has done to address youth suicide rates. So the White Mountain Apache tribe, in partnership with Johns Hopkins University, has implemented a culturally responsive suicide prevention program that has 4 components. I'll be going over 2 of these components, the New Hope Intervention and the Elders Curriculum. The New Hope Intervention is a culturally adapted practice that connects youth who have attempted suicide with traditional healers and caring adults to give them a safety plan. The Elder Curriculum is a complementary approach. The aim of the Elders Curriculum is to promote mental health and resilience among their Apache youth and is focused solely on cultural strengths, Apache knowledge, language, and stories. Elders build relationships with youth in schools and likely will not even talk about suicide. It is a practice promoting strength through the knowledge, stories, and songs of Apache elders. This asset framing approach to Native American youth suicide prevention decreased the reservation's youth suicide rates by nearly 40% over 5 years. Having and consistently using an asset framing lens allows policymakers and programmatic leads to search for, promote, and advocate for practices and policies that use community-defined evidence and cultural strengths, much like the White Mountain Apache tribe's curriculum for youth suicide. Right? And asset framing provides the space for communities to define, practice, and share what works for them, and for researchers, policymakers, and programmatic professionals to view community-defined evidence as credible evidence that should be used in the whole of our evidence-based decision making. I think that's it for me.
Thank you, Michaela, and thank you for that deep dive. I think the way that you framed that and really showed how the way we frame our work has those kind of implications on narratives is really critical. So we're going to build off of that now and share a tool that AmChip has put together that's really a way to both ensure that when you are considering potential solutions to MCH challenges, there are ways that you can do that both centers an assets-based lens to how you're describing the MCH challenges or opportunities for growth, as well as also an assets-based lens when thinking about what is already working to ameliorate some of these challenges. So the tool that we're going to be talking about today is called the 6 Considerations Planning Tool, centering people with lived experience when exploring solutions. There are 6 main questions that you ask in the tool. The tool is really designed to be used with teams. So an example I like to give is, let's say a notice of funding opportunity comes out for addressing adolescent mental health or adolescent suicide prevention. When considering what potential solutions you might put forth for that funding opportunity, you can ask yourself and your team these series of questions. A really important thing that we'll get into, this is designed to be done iteratively. So as different people join your group for conversation, to kind of always center back and ask these questions. So we have who's impacted, how will they be engaged, what's the need, what's working, what else might work, and what's the evidence. So a quick terminology check. In the tool, we use the term priority population. That is inclusive of people with lived experience and collectively refers to all individuals and groups directly impacted by an MCH challenge, as well as the potential solutions to that challenge. So the tool itself is like I said, it's really a discussion guide and a planning tool. And if Noelle, if you don't mind chatting in the link to the tool, that would be wonderful. So folks can take a look at it. We'll also be sharing a recording of the slides, recording of the webinar, the slides, and the tools and examples that we've mentioned in a follow-up email to all registrants. So fear not if you can't open it right now. So the way that you use the tool is for each of the questions, you first draft a response, and then you pause and do what's called a perspective check, answering the questions, how do we know this information and whose perspectives are we missing? So when we pause to think about who's impacted, right? Or what's the need, for example, wanting to stop and pause and think, how is it that we know this? Where are we getting this information on what the need is from? Whose perspectives are we missing? If you realize that there are important perspectives that you are missing in understanding what the needs are or considering potential solutions, you want to stop and think, who else should we talk to for this information? And then what other information might we need to gather? So now we're kind of do a deep dive together of the tool before actually applying it to an example. So for our deep dive, who's impacted, right? So that's our first question. So who is the priority population impacted by this MCH challenge? And so this is really important that oftentimes when I work with teams using this tool, this is one of the most challenging questions that folks have to answer, because really narrowing it down to who exactly are you looking to work, like who is your primary population? Who is the most impacted by this? For example, for workforce challenges, if you're doing something, maybe you're located in a jurisdictional health department, you're doing a workforce practice, you're trying to address a workforce need, your priority population might be your section staff or your bureau staff, however it's set up. For another program, it could be birthing people or parenting teens or whoever it may be, right? So it's really important that first and foremost, we kind of narrow down who is the primary priority population impacted by this challenge. And then stopping to think, how will they be engaged in the solution brainstorming and selection process? Who should be included in the process? What support will they need? And how will you ensure their voices are centered throughout all decision-making processes? It's really something that we do really, really well within Title V is during the needs assessment portion of understanding the kind of MCH landscape of our different jurisdictions. We're really great at including people with lived experience during that time, but how do we extend that further to not just the need generation, but also the priority setting, selecting strategies, really developing our action plans? Like, how can folks be engaged throughout that? And then what supports are needed to ensure that that engagement isn't tokenizing? Could be also, how do we make sure folks are supported? So that could be through childcare, that could be through transportation support, through compensation for their expertise. So just really thinking through, how are we supporting them? And then how are you ensuring that their voices are centered throughout all decision-making processes? Next up is, what's the need, right? So really thinking about, now that we've taken the time to identify who's our priority population and thought a bit about how they're going to be engaged, what are their needs? So thinking about like what the actual needs are, but then in addition to that, how was the priority population engaged to assess their needs? And how do folks perceive their own needs? So this is another opportunity, as Michaela was talking about with assets framing, kind of shifting power away from that, like experts coming in saying, this is what we think your needs are, to really shifting that power to people's lived experience, to community voice, to share what their own needs are, and make sure that they are really the ones defining what the need is. This is often a time I find using that perspective check is important, to think about, where are we getting this information from, and who else might we need to talk to get a more comprehensive picture of a need. Next up, we have what is working, right? So this is really when we stop to think and really intentionally apply that assets framing to think about what approaches to address these needs are already working for or within the priority population. There's often really great work underway, and we don't always need to reinvent the wheel. We don't always need that kind of shiny new, we're always looking for that silver bullet, right? It's human nature. We want that quick fix, that quick answer to solve different challenges, but oftentimes there's work already underway that we can bolster, that we can fund, that we can scale up. So first thinking, what's working? This is often a really important time where to think about, well, who might we need to talk to understand what's working? It's very often that the folks kind of having these initial conversations when making, when considering what solutions we might want to pursue for grant opportunities, or just different, even for our state action plans, for different strategies, really thinking about who do we need to talk to understand the full picture of what's working. Next up is thinking about what else might work. So this is when we look beyond what we currently know to maybe look at other solutions that exist within our jurisdictions or in others that might address the needs of the priority population. And then the last step is really to think about, what's the evidence? So what types of evidence were you exploring when brainstorming potential solutions during the what's working and what else might work sections, right? So kind of harkening back to what we talked about earlier about those three different types of evidence. Were you mostly looking at research evidence, or were you only looking at contextual evidence? And maybe we want to look at what's the research evidence out there for different types of solutions to the challenge that we're looking to address. And then the last is a reflective question. And moving forward, how can you better balance the types of evidence you considered while also centering the voices of the priority population? So I don't know about y'all, but I am an experiential learner. I learn best by doing. So we are going to actually use this tool together on a case study. So imagine you're in the largest city in a southern state. As a local health agency staff member, your maternal child health team is seeking to promote doula care to advance birth equity. You've been tasked with exploring and providing recommendations to leadership on sustainable and equitable approaches for compensating community doulas and integrating doulas into local hospital systems. Discuss your policy options and approaches using the 6 considerations planning tool. So first up, who's impacted? So when thinking about this, we're going to want to think about defining our priority population. So based on that example, our priority population is going to be local doulas in your large southern city who could benefit from being compensated and being integrated into local hospital systems. So what I want to note here is, what's interesting is our priority population are not the birthing people who benefit from having doula care, because the policies and programs we're looking at really are going to center on the actual workforce, on the doula workforce. So even though ultimately we want to also be ensuring that birthing people are having the best possible birth outcomes and having the most culturally congruent and respectful birth experiences possible, our focus for this brainstorming is going to be on local doulas themselves. So when we're thinking about who we want to be engaging, when we're considering these solutions, it's going to be the doula workforce. How will they be engaged? So you're sitting with your team and you're thinking, how might we engage different community-based doulas when thinking about these solutions for their sustained compensation? And so someone has the idea of creating an advisory board comprised of local doulas who will be involved in crafting the policy with the local hospital systems, Medicaid, whoever it may be that you want to include. But you then do your perspective check of how do we know this? Who else we might want to talk to? And you realize that there are no one in the conversation is actually a birth worker themselves. We all work at the jurisdictional level. We don't have that experience. And so you realize that to think about how we're going to want to engage these birth workers, you're going to want to have conversations with your existing partners who are birth workers or folks that you're hoping to work with. To really just ask them and talk about like what are the ways that it would be the most effective for you based on your bandwidth, based on your interest to engage with us. Will you need compensation to work on a work group? What work group supports would you need? What's the timing? So just really our goal with this is to give us space to be reflective, to co-create with the folks we're aiming to serve. So then what's our need, right? So some of the needs you've identified, and this comes, you have done some focus groups with birth workers in your state prior about their needs, and this is where this information is coming from. And you know that doulas need to be compensated for their services in order for it to be sustainable. Doulas need to be more integrated with local hospital systems, and birthing people in your city need to have sustainable access to community doulas to help address maternal mortality and morbidity outcomes in your community. So now that you feel pretty clear on, okay, so these are some of our needs, you think about what's already working. So in your discussion with your team, one of you mentions that you've heard about an existing partnership between one community-based birth center and a local hospital in which doulas are integrated into hospital care teams. So that's really fantastic, right? Because when you're going to think about these approaches, you have a building block that you can kind of build off of as this is already working well. What conversations can we then have with these individuals to learn about their process, to learn about their internal policies that maybe you can replicate or scale up, right? So really wanting to first think about, well, what's working well? What can we build upon? What relationships already exist that we can leverage? So we're pausing to think about that. And again, doing our perspective check of how do you know this? This might be a really great example too, where you realize, okay, this is what we know within the knowledge in the room, but who else should we talk to get a better picture of what's working in our jurisdiction? Then we start thinking about what else might work. So this is where we look outside of just our city, for example. And so you know that you've just heard about New Jersey and other states, Minnesota, like there's some really great examples throughout the country of where doula care is covered by Medicaid. And so wanting to think about what that looks like and learn from them. So that's an example of kind of we're looking elsewhere. A lot of this is looking at more research-based evidence when you're kind of doing research on your own, talking to colleagues that you might have in other jurisdictions who you've met at different conferences or events, learning about what's going on outside of your own area. And then lastly, we think about what's the evidence, right? So this is this kind of meta reflection moment at the end of your conversation using this tool, thinking about, well, what were we considering when talking about when considering potential solutions? So you realize that you were kind of looking at a good mix of evidence for the what's the need and what's working sections. You were mostly looking at experiential evidence and contextual evidence. And then for what else might work, you were mostly relying on research evidence. So you're feeling pretty good that you are looking comprehensively when making your evidence-based decisions. So at the end of this tool, really what we're hoping for and where you're going is you now feel like you've taken the space in a structured way to think comprehensively about what is out there, what are the approaches you might need to address needs, what are the needs that you might want to address, and then from this, have a bit of like a laundry list of these are potential solutions we might explore, policy solutions, practice solutions to address your need, and you can feel really confident that once you use this tool multiple times with other groups of people who you've identified might have been missing from initial conversations, that what you ultimately end up choosing to pursue has been deeply rooted in the available evidence, and that you're looking at that contextual, experiential, and research evidence when making your choices. So that is the end of our sort of content for you today. We have an evaluation poll we'd love for you to fill out that Noelle's going to launch in just a moment here, but also welcome any questions that you have. I know this was a lot of information, but hopefully you're feeling like you have a little bit more of a structure and a framework for how you can make evidence-based decisions that really center the folks that you're going to be serving and apply an assets framing to how we consider needs and narratives and consider solutions to MCH challenges. So I'll give folks a second to complete the evaluation. And then we'll take any questions. Feel free to chat them into the Q&A feature. We've had a couple questions come through throughout. So. And then lastly, while you're doing this, stay tuned for next year for more. We'll be sending out information about upcoming Innovation Hub Learning Community opportunities in 2024. And feel free to chat in any questions that you have. If you have any, we'll stay on for another few minutes as folks are continuing to complete the evaluation, and we're here to answer any questions. But thank you so much for your time and engagement today. We hope that this was useful for you, and a recording of this will be on the website, and we'll be sharing out the slides and resources with folks who registered for the webinar as well. Seeing a request from Michelle. I would love a part 2 of how to influence your org to shift to asset framing. So really, this is well timed. We are doing planning for webinars to cover what we want the webinars next year for the learning community to cover in a couple weeks. So that can definitely be arranged. So thank you for that suggestion. All right, well, everyone, thank you for completing the evaluation. We appreciate you doing that. We've had everyone participate. So if there are, we'll stay on another minute if there are any questions, and if not, we will wrap up for today. Well, thank you all so much for your participation. And I hope that you have a wonderful day and holiday season.
Thanks all.